I allowed Datuk to share his sharing today, let me read out his profile, okay, his prestigious profile. So today, our speaker for today is Datuk Dr. Abdul Aziz. He is currently a consultant obstetrician and gynecological oncologist in Gleneagles, Kuala Lumpur. After graduating with the MBBS from the University of Malaya in 1982, he obtained his qualification from the Royal College of Obstetricians and Gynecologists in London to become specialist obstetrician and gynecologist in 1988. He spent another 2.5 years at the St. Mary's Hospital in London, where he undertook further training in gynecological oncology. His contribution in this field is well known in the Asia-Oceanic region. He was the past chairman of the Gynecological Oncology Committee of the Asia-Oceania Federation of Obstetrics and Gynecology, AOFOG. He has published extensively in the areas of the gynecological oncology and frequently gives lectures and conducts surgical workshops. He now performs regularly robotics-assisted gynecological surgery for both benign and malignant conditions. He is currently the president-elect of the Asian Society of Gynecological Robotic Surgeons, ASGRS. Dr. Abdul Aziz was also recently awarded an honorary fellowship, FACOG, of the American College of Obstetricians and Gynecologists for his contribution. That is impressive. Okay, Datuk, thanks again for being with us. So without further delay, I shall pass the floor to you. Thank you, Datuk.
Well, good evening and thank you very much, Amy. It was always a pleasure to talk to people, but I wish we can speak face to face, but in reality, with the current scenario and situation, this is how this is going to be done. And it is, I've done a few webinars. It's only easy to fall asleep, especially when you can switch on your video and go to sleep and do some cooking as well when the speaker gets a bit boring. My intention today is not to do anything too difficult to understand, because I do understand that medical terminology sometimes can be misleading and it's easy for people to misunderstand and come up with the wrong idea about certain conditions. So my intention today is actually, first of all, to talk about some of the common gynecological cancer that we are dealing with now, and then to spend a little bit more time in the second part of my lecture to talk about cervical cancer specifically, because this is such a disease. Cancer of the cervix is so preventable. It's a shame that we still get women coming to see me with cancer of the cervix, either stage 2, 3, or 4, or whatever. It is a disease that should have been eradicated from the face of the earth, because we do have certain ways of dealing with the disease to prevent it from surfacing. So I'm going to spend a bit more time on that one. But broadly, the first part is going to talk about all the various gynae cancer, including cervical cancer as well. Slide, please. Serena? I'm just waiting for my first slide to come through. Nothing. Well, this is how it works sometimes. It doesn't work or it works. I am seeing Amy's face on my screen, but
yes,
not my...
I can see the slide moving.
Oh, I can't see.
Maybe all right. Sorry, that's helping.
Yeah, don't worry. We'll sort it out in a short while. Yeah. Share screen.
I suppose that I can see the slide. Sorry, Amy, I only can see your face. I cannot, doctor cannot see the slide. Wow.
Baby, are you able to do the gallery or speaker or standard view?
All right.
The top right?
So
Okay,
it's up now.
Yeah, great.
It's okay. Technology is always like that.
Yeah, it happens.
Okay, now cancer of the cervix, see, in gynecology, gynecological cancer, the commonest is still cancer of the cervix. It obviously, as you know, the uterus begin with the cervix and it becomes the uterus, and further up, it becomes the ovaries and the fallopian tube. Now, when someone gets referred to me for cancer of the cervix, first of all, we need to know what stage the cancer is. As you know, it is divided broadly into 4 stages, stage 1, 2, 3, and 4. And there are, in every stage 1, 2, and 3, and 4, there are certain other sub-stages. Now, of course, stage 1 is the earliest. And then we come stage 2, 3, and 4. Now, when the cancer is still in a very early stage 1 disease, sometimes it is possible, if the need arises, especially when the woman is very young, single, or recently married and haven't got children, it is possible to actually do what we call conservative surgery or fertility sparing, meaning she doesn't have to lose her uterus yet because the cancer is so small in terms of volume, and it's stage 1A1, we call it. It's very small. And in this case, we just remove the cervix and we maintain the uterus intact, yeah? And this procedure is called trachelectomy. It is quite a complex, difficult surgery because it's trying to be conservative. So we need to cut off the cervix and repair it back so that it maintains a certain strength to ensure that when you become pregnant, the pregnancy will not come up prematurely. The thing about trachelectomy or conservative surgery in cancer of the cervix is that when the patient becomes pregnant, there is a risk that she may go into premature labor and all the other problems related to premature labor. I currently have a patient that I'm currently treating, who referred to me all the way from Thailand. She married local, who had this whole problem, and we have done successfully, and she's currently pregnant. So that's a good, happy story to tell. But the point is, you must come early and see us so that we can prepare you to have a conservative surgery. Now, the next step is, if you have already cancer of the cervix, there's nothing much more we can do. It's already advanced stage 1B, for example. The cancer is looking very angry at when we examine the patient, and she's been symptomatic. And usually the symptoms are, especially if the woman still having her period, her bleeding is going to become abnormal, very prolonged. Even though the menses has stopped midway, a week after this, her period has stopped, it may come out again. Those sort of symptoms are no good. And the most important symptom that a woman, a lady, shouldn't ignore is when she has bleeding during or after intercourse. And that is the most cryptic and synonymous with cancer of the cervix, unless proven otherwise. Of course, there are other causes of you bleeding after intercourse, but cancer of the cervix must be ruled out. The other symptom that normally these cancers sort of tell you they are there is usually you have a lot of persistent abnormal vaginal discharge. Now, I like to explain about vaginal discharge. A woman who's not menopause will have vaginal discharge. Now, the normal vaginal discharge usually a bit whitish, quite copious, not so thick. It is more watery, especially when you are about to ovulate, for example, you're about to produce an egg. When you're fertile, the discharge is typically described as the egg yolk. I mean, the white of the egg when you open an egg, yeah, not the yolk, the white. So that typically is normal. So what is not normal? Not normal means it is blood stain, smelly, it has an odor, or the color keep on changing to either green or yellow to signal there's some kind of infection. Now, cancer, when it's growing, can get infected. So once confirmed, we take a biopsy, it's confirmed to be cancer. Now, experienced surgeon, gynecology will look at the tumor, will look at the cervix, say, you have cancer. But for medical legal purposes, we have to prove it. That's why we still have to take a biopsy to confirm that it's cancer. More so because there are different types of cancer of the cervix, and each of them behave differently, though the treatments are the same. So let's say the commonest cancer, if you want to go into the detail, The commonest type of cancer of the cervix is called squamous. About maybe 60–70% of the time is a variety called squamous. But the other variety, about 25–30%, belong to the type called adenocarcinoma. Now, they are more aggressive, and they are more difficult to treat in terms of to try to make you remain tumor-free for at least 5 years. Now, so when we do radical surgery, patient have to understand also it's a high-risk operations. A lot of time, patient ask me before I embark on the surgical technique, they always ask, is the surgery risky? I always tell my patient, any surgery we do is risky, whether it's cancer or non-cancerous conditions, because we are taking over your body, we anesthetize you, we stay in the hospital, we use instrument that's sharp, instrument that's hot, complication can happen. But of course, the surgeon will take what we call informed consent so that you understand exactly what the surgeon is going to do. And complication may arise, not intentionally sometimes, but because the nature of the surgery. How do we do it? Because the cervical cancer and the bladder and the rectum are all neighbors. They're all close by. They share almost the same wall. And the surgeon had to remove this cancer and take it away from the wall of the bladder, away from the wall of the rectum, delicately, so that he won't injure the bladder and the rectum. If you imagine you stay in a semi-D house, for example, or a link house, you have two neighbors. If you want to break your wall because you want to repair your wall, you may have to tell your neighbor, because you may cause the damage to your neighboring wall as well, because it's the same wall. It's the same thing with cancer of the cervix, because the wall that the cervix is sharing with the bladder and the rectum. So the surgeon has to delicately remove the tumor without injuring this bladder. So complication can happen. But in the end of the day, I always tell the patient, you have to balance out what is the risk of you continuing with the cancer in your body and the risk of me doing my operations. We do this operation almost on a daily basis, and obviously, as you do more often and more frequently, you become quite good. But no surgeon will be telling you, I'm so good, nothing will happen to you. I think that if a surgeon say that, he's quite silly, because we do know even the best of hand, complication can happen because patients themselves have issues. They could be obese, they could have medical condition like diabetes or hypertension, right? So whenever we do surgery, this is true for all the other cancer that I'm going to talk about. The surgical problem is the same when we do what we call radical surgery. When you have cancer, it is a radical surgery that involves removing the uterus, the cervix, of course, and sometimes both ovaries have to come off, and a bit of your vagina. I'll show you a photo later so that you understand. A bit of vagina, which is close to the cervix, has to be cut off. So before surgery, let's say your vagina is 6 inches long. After the surgery, it's going to become slightly shorter, maybe by an inch shorter. We need to remove the upper part of the vagina because it may contain cancer cells as well. So it's a bit more extensive. And the most difficult part of the operation, apart from what I said just now, are the lymph nodes. In your pelvis, there are many types of lymph nodes. Lymph nodes are, some patients say, oh, you're removing my lymph node, so I'm going to have lymph nodeless. That's not quite exactly true, because you have thousands of lymph nodes all over your body, right? They have a role to play, of course. But they are also a good hotspot for cancer to stay there and hide. So they have to come out, both in your pelvis. So we're removing lymph nodes in the area of the cancer, which is in the pelvis. So the pelvic lymph nodes, we call it, have to be removed carefully. The problem with these lymph nodes are they don't come out without a fight, because they live and stick on to the blood vessel. And the blood vessels in your pelvis are very large and very big. So trying to remove the lymph node that is sticking to the blood vessel can be also a potential source of bleeding and hemorrhage. And obviously, sometimes the patient will need blood transfusion after surgery, if that happens. So it's a high-risk surgery, but nothing compared in terms of risk for not doing anything for your cancer, because the cancer will progress on and make you very, very sick. All right. So not only that, after surgery, we've done it. Why do we remove all these lymph nodes? And because we need to know whether the tumor has spread to the lymph node. So the whole specimen will be sent away for assessment by the pathologist. Now, the pathologist will tell me, well, this patient is lucky because her cancer is still quite early, it just confined to the cervix. So it's really stage 1B, for example. Yeah, it's still very early, hasn't spread to the lymph nodes. So the patient will be told the good news, because I say good news because she will not require further treatment with radiotherapy and chemotherapy, because these two other treatment will become essential and necessary post-operatively if the lymph nodes are positive, meaning the tumor has spread there. So even though it's stage 1B, but the tumor has spread. So we wouldn't know how far further the tumor has spread. So therefore, we need to give you radiotherapy and chemotherapy. So that is not good. In terms from insurance purposes, obviously, that will add cost to the patient's treatment plan, and she may even bust whatever insurance policy she has, because chemotherapy and radiotherapy can even be more expensive than surgery. All right, so that is under the category of what I call adjuvant therapy here. All right, that's after surgery. Now, sometimes patient comes so advanced, stage 3, for example, stage 4, nothing much we can do. So we have to palliate. We have to take care of her to her last days, because we cannot just say, oh, sorry, I can't do anything. That is wrong. As a gynecologist dealing with cancer of female organ, I know we don't dump people, even though, let's say we saw the patient a year ahead, and she was still quite early, but she ran away and tried her own method of treatment, either naturopathy or just deep praying or whatever she does or she did. The cancer grow and grow and grow and cause a lot of damage. Because I told you just now, they share the same wall with the rectum, the anus, and the bladder. The cancer will eat and eat and eat and drill a hole in the bladder, drill a hole in the anus, so that she pass motion and she pass urine out in together, coming out through her vagina. Can you imagine a situation like that? It's going to be so smelly. For the caretaker at home, they find it unbearable. I've seen daughters and sons looking after their, so-called terminally ill, advanced cancer mother. I tell you, it is so stressful. Some they even have to give up their job, they have to stay at home 24 hours, kind of looking after this lady who is leaking from the vagina containing urine and feces. Do you want to go there? My answer is, I don't think you want to. It's easy to say, it's okay, don't worry, don't touch me, doctor, let me be. But you will want to know what happened to you in the end. So I look after a patient like that. So I know it's going to be a challenge. So therefore, when we come to a treatment for a patient like that, we do what we call combination treatment. Yeah, we can't do much. It's come under the category of terminal care or palliative therapy. So the treatment will depend on the stage of the disease. Yeah. So we look and make you comfortable. Make sure you are clean. Not by cleaning you up all the time, but we try to do diversion, we call it. We try to divert the bladder so that she passes urine through the bag. We try to divert her anus so that she passes urine through her, she passes motion through her bag as well. So the vagina become very clean. So she will still go on and succumb to the disease, but at least she's not smelly. So these are a few things we can do to make life bearable, not only to the patient, more so to the people who's looking after her. And I've seen so much stress in family members and caregivers dealing with women in the end of her life when she's fighting with cancer of the cervix. Next slide, please. Next one. Yeah. Okay. I mentioned to you just now about how much of the disease that we have to remove. Now, it's not so gory in organ. Don't worry. I saw Amy's face change a little bit, but not to worry. I don't know about the rest. Yeah, don't switch off your camera. I mean, your video. Okay, I told you just now, this is the cervix, yeah, where the main cancer started from. That's the cervix. That's the top of the uterus. That's the ovary, one side, another ovary on this side. Now you see this white fleshy skin. Now this was part of the vagina. I told you just now, with this cancer, we have to remove a certain portion of the vagina as well, because cervical cancer can reside or hide in the vagina as well. So a part of the vagina has been removed. So the vagina becomes shorter. Then I told you about the lymph nodes. All right. This one set of the pelvic lymph node on the left side, another set of lymph node on the right side. So these are the lymph nodes that we removed. So we just clean up nicely, took a photograph for teaching purposes. These are all real cases belonging to my patients. There are some more photos. Will you show you? Next slide, please. Okay, this cancer is larger because just now I showed the cervix. This is still the cervix. This is still the uterus. This is still the ovary. This is still the ovary. This tumor is bigger than the first one. This is the main tumor here. All right, and again the lymph nodes there, left and right. So these are some examples of tumors that we have been removing on a regular basis. Next slide, please. This is even larger. See how big it is? So it progresses, you see. So cancer of the cervix, if I tell you have cancer today, I already diagnosed you with cancer. I already tell you what stage it is, and it is operable. Why wait 2 weeks? Why wait 2 months? Why wait 2 years to do this? Because cancer, the reason why I show how it grows, because cancer of the cervix is a disease that's living. It's a living condition. It's alive. It want to take over things, you know. So it's keep on growing at your expense. It grows because it take away your nutrition. You take a lot of food. You know, you take a 3 kilogram piece of steak. They all go to the cancer. You just wasted your money eating all the good food. Because cancer want to survive. So they are like parasite, but they are nasty parasite. They're not parasite they can swipe off, you know, but they stay there, grow, and take over. Next slide, please. All right, so that is cancer of the cervix broadly, but I will come back to cancer of the cervix because I think that is one cancer where I wish I see less. I wish I don't have to operate so often on these women because there are ways of preventing from coming to that level. All right, we'll come back to that in the second part. So now we talk about the other common cancer. Now, cancer of the cervix that I said just now, the first part, cancer of the cervix usually happen in women who are still menstruating before menopause, commonly. So therefore, when you have abnormal menses or bleeding after intercourse, you tend to come and see the doctor. You should be coming to see your regular gynecologist to sort it out, or to be examined, to come up with an idea of what's wrong with you, why you're bleeding. But cancer of the uterus is a bit different. Now, cancer of the uterus tend to happen in women who are menopause. All right, menopause means you stop having period naturally. Most ladies these days, by the time they reach 50 or 52, they start having they stop having period. Yeah. By definition, menopause is when you have no period continuously for 6 months, proven by a blood test. We do a blood test to check hormone and certain ovarian hormones to see whether they're still there or not. So if you have no period for 6 months, and plus the fact that your blood test confirmed there's no more hormones in you, you are menopause, and you shouldn't have bleeding. You shouldn't have period. All right. So, as opposed to cancer of the cervix, cancer of the uterus is always mainly often diagnosed early. The reason is because a woman who's menopause, because this is a disease commonly happen in menopause women, with a few exceptions, which I'll come to that in a short while. Majority of them are menopause. No period for a year. One fine day, they got up, they went to the loo, or they were sleeping. Suddenly they will see a patch of blood on the bedsheet or in the toilet bowl, or whatever. Meaning she had developed what we call post-menopausal bleeding. I have stopped having periods, suddenly I bled again. So because of this, a lot of women like this, they come and see their gynecologist early, you know, because they're not happy. Hey, I maybe have no period. How come you came back? You know, something is quite wrong here, you know. So the gynecologist will examine, will take a few history, because often some of these women actually have piles. They didn't know they had piles, you know, and they bled. And so that's why I say, you know, 75% of our diagnoses are sometimes spent talking and asking relevant questions and insisting that the patients answer them accurately and truthfully. History taking is still the mainstay of making a diagnosis in our field in medicine. So do not feel offended when the doctor asks too many questions, because 75% of the time he can make a diagnosis without examining you. And that aspect of care has remained the same through centuries of whenever we practice medicine. If the doctor doesn't ask you a question, doesn't talk to you, just want to examine you right away, I do not think he's doing the right thing. He should be asking you more questions. Yeah? Don't get offended. He may want to ask you certain relevant questions. Answer him truthfully. But nowadays, I see this cancer happening in much younger women. And not just that's not just my experience recently, but in the last 20 years or so. Even when I was working in Britain and back home in Malaysia, I see that this cancer is happening in much younger women, meaning women who have not reached menopause. They get the same cancer. All right? This is all related to obesity. Obesity in Malaysia, we in Malaysia are great people. You know, we are number one, I think, in the world currently in terms of the obesity index, and it has been mentioned many times. Obesity is related to sedentary lifestyle, dietary indiscretions, eat too much, drink too much, not running enough, kind of thing, you know, and it's a problem here. Okay, obesity is one reason why we're seeing a changing trend in this cancer. The other condition that is related to obesity is called polycystic ovarian syndrome, PCOS. And this is a condition that's more common these days, easily treatable without surgery, with medication we can treat you, is related. They are related, PCOS, obesity usually. But not all patients with PCOS are obese. I've seen some tiny, nice little ladies with PCOS. And PCOS means your eggs cannot come out from your ovary because they are got trapped within the ovary. Why do they get trapped? They're supposed to escape. They're supposed to come out every month. We call it ovulations, yeah? But that's because a layer of fat has developed over your ovary. There's a capsule of fat covering the ovary, and this egg on the way out is being blocked by this wall, so they stay back and form little follicle. That's why we call it polycystic. But it's more common in obese women, all right? There are also this condition these days, women are into, well, I can't blame them, you know, they have been under the thumb of men for too long. They want to go out and have a career and, you know, marry late and that kind of thing. So subfertility has become an issue. Subfertility doesn't mean you can't conceive. It's just that either you delay your fertility or you've been married, been trying, nothing happened. And when you go see a fertility specialist, you get tested, and they say, oh, there's nothing wrong with you. Both of you, you are fertile, you're ovulating, your husband's sperms are fine, but you're not getting it. So maybe it's pure bad luck or something is not quite right. So subfertility and delayed conception contribute to the changing trend of this cancer of the uterus. All right? Same thing. When the patient comes over, regardless of her age and whatever, not when we suspect this condition, we will have to make a diagnosis. And diagnosis is usually by a procedure called hysteroscopy and DDNC, meaning of course you'll be asleep. Yeah? You come to the hospital, the daycare procedure, the doctor will put a camera into the uterus, look at the lining of the uterus, because this cancer will come from the lining of the uterus. So, doctor will look at it, won't confirm it there and then, but he will sample this lining, take it out, and send for testing and the pathologist will tell him, yes, it is there. Sometimes this cancer exists in a pre-cancerous stage. They're not even cancer yet, but they're changing. They're going in that direction. So it hasn't become a full-blown cancer yet. When we diagnose that, we call it cystic hyperplasia. Sorry, it's fasting, my throat become very dry. We call it cystic glandular hyperplasia. There are two types. These are precancerous, they're not cancer yet. There are two types. The not so bad one is called typical cystic glandular hyperplasia. The one that's going to become cancerous is called atypical cystic glandular hyperplasia. Of course, you don't have to confuse your mind. Let us deal with all these various types. So, but when you are at that level, it's not cancerous yet. The doctor will not suggest, let's take out your uterus. Unless you are 50 plus years old, you already got 5 children, that kind of thing, you don't mind. But you're still single. Yes, I'm obese. I'm single. I'm not married yet, you know. Or I'm married, but I haven't had children yet. I want to be conservative. Can I get a conservative treatment here? The answer is yes, you can. but there are certain strict protocol you have to adhere to. Your doctor will tabulate or should tabulate to tell you how you're going to treat you conservatively. It is possible to do that, right? Provided it is at that very early stage. But then if you do your part, you follow the medication and come back for regular follow-up. And this treatment usually involves this medication called metformin and oral contraceptive pill. These two tablets, first of all, we give metformin. Metformin is a drug mainly used for treatment of diabetes, but it's also useful for condition of PCOS and early precancerous lesion of the uterus. This is to minimize the thickness and make sure that the endometrial lining become more regulated. And if you are going for a conservative treatment, your doctor, after you've gone through, let's say, a year of this conservative treatment, will reanalyze your uterus by doing the same procedure when he made the diagnosis in the first place, meaning we do hysteroscopy and the DNC again. If it is not there, you're good. Try to get pregnant, right? Don't waste time. Lose weight. Start eating well. Take more greens and all the good things you know you're supposed to do, but you don't do, right? Start running around, exercise, that kind of thing. I don't think we have to tell you all that. Everybody know what a good lifestyle is, I don't think we need to spend a lecture telling you what a good lifestyle is. I mentioned just now about repeating, monitoring, and hysteroscopy. But when the cancer has become cancerous, when the lesion has become cancerous, especially when you're 50 years old or 50 plus, you're sick, or you're 60 years old, you develop postmenopausal bleeding, the doctor has diagnosed you have cancer, or even though early cancer, I don't think you want to go for a conservative route. I do not think you're going to be, you want to be offered a conservative treatment at the risk of the cancer coming back. So the doctor will advise you surgery. Again, it's a radical surgery. It is similar to the surgery that I showed just now for cervical cancer. The only difference for cancer of the uterus is that we can also offer a keyhole surgery. In the last 12 years, because a patient with cancer of the uterus usually come with other comorbidities. They may have diabetes. They may have high blood pressure, because these are mainly menopause women. And they may have other conditions, like maybe some of them have even gone for stenting of their heart, blood vessel, that thing. They are high-risk people. Doing radical surgery by the opening method, by opening up the tummy, like we do for cancer of the cervix, carry a lot of risk in terms of recovery for the patients. In the last 12 years, I've been doing robotic assisted keyhole surgery for these cases, and we get excellent results in the sense that the scars are not big, they are just small little 4 little holes in your tummy, right? And we remove exactly the same amount of tumor together with the lymph nodes and all that completely. And the recovery is excellent. The patient may not have to stay in hospital for 10 days as opposed to an open surgery. The patient will just have to stay about 3 days. And when they are discharged, they will actually walk to their car without need of a wheelchair. You should understand this. From the doctor perspective, for us, we have done a good treatment when our patient recovered well, very minimal blood loss. They do not need ICU care. They came in walking, they go out back to their car walking without aid of wheelchair. Isn't that great? That's a good method. That's a good technique. That's from our perspective, and also from the patient perspective. Now, I'd like to say this now, because we are dealing with insurance guys here. Because I think we need to understand this. I always like to make people understand, because I think we made the wrong decision because we do not understand. So we need to understand first. I'm repeating myself. From the perspective of a patient, from the perspective of a doctor, a surgery, a treatment that offered to the patient is good when the patient can be discharged well and can be productive ASAP. Meaning, if she's a lawyer, 2 weeks she can go to work. If she's a doctor, 10 days, 2 weeks she can go to work. She can drive cars and that kind of thing. And mind you, surgery was done for cancer, where in the old days, perhaps 4 to 6 weeks they had to be an MC. They have to stay in hospital for about 10 days sometimes. All right. So maybe Prudential may want to look into this, because often when it comes to a new technique, a lot of the time insurance company say, well, it's a new technique. No, it's new to us, but it's not new in the US. In the US, they've been doing it for the last 25 years. I started in Malaysia 12 years ago. Singapore was way ahead of us by about 3 years ahead of me. So in Singapore, they started about 15 years ago. Thailand is not far off. In South Korea now, majority of gynae cancers are done robotically. So it is not experimental. It's not novel. It should be the standard of care to me when you have cancer of the uterus. Cancer of the cervix, we don't do robotic because there's already a publication that came out saying that if you do robotic for cancer of the cervix, the first cancer, the prognosis is poorer because the tumor can spread, because the location of the tumors are different. For the uterus, it is recommended that we do keyhole robotic surgery because the cancer is confined in the uterus. I'm going to show a picture now. Next slide, please. Sorry. You see, this is the uterus. The cancer is in the uterus. This is the cancer in the uterus. This is the cancer in the uterus. Whereas cancer of the cervix happened here. So when we do robotic surgery, keyhole robotic surgery, there's a lot of manipulation here, and we can help the tumor to spread. Whereas cancer of the uterus is confined in the uterus. We don't manipulate in any way. That's why it's highly recommended we do that. Because patient with cancer of the uterus has morbidities, they're obese. Cutting the skin of an obese woman during surgery, open surgery or conservative, the typical open surgery, cut through layers and layers of fat, and recovery can be very, very slow. All right. So I'm not going to repeat that, but anyway, you can figure out for yourself. If you yourself have come to this kind of condition where you have cancer of the uterus, when I mentioned about being productive and recovery rate being better, you will obviously agree that robotic surgery is the one that you want. But fortunately nowadays, the insurance are a bit more friendly to us. In the past, they will say, no, this is something new, patient pay themselves if they want, and then pay and claim. But now I think Prudential and a few others has allowed patients to what they call it, co-pay. So Prudential or their TPAs will pay to the amount of an open surgery and the extra that they need to pay for the robotic surgery, because robotic surgery is a bit more expensive than open surgery. The patient will have to pay themselves, called co-pay. So if the patient is happy with that, then we'll proceed. Sometimes patients say, no, I'm not going to pay a single cent, then I have no choice but to do an open surgery, right? So which is sad, I think. Next slide, please. Now we come to the other cancer, which is also difficult to treat, the cancer of the ovaries. Now, the problem with this cancer of the ovaries is that they are pretty unique. Now, a lot of women do not understand where their ovaries are. I have a case, which is true, because I have cases where when I operate someone with a big fibroid, I just remove the uterus. I say, we're not touching your ovaries, okay? We're leaving your ovaries behind. The obvious question to ask is, oh, what happened? My ovaries will be running around all over my belly, right? Because you don't understand the anatomy. Ovaries have their own attachment. Attached to the back of your bone is there. They don't run away just because I leave them by themselves. They don't do that. So, cancer of the ovary, if you take a pail and put on the floor, a bucket, put on the floor, and throw 2 marbles to the bucket has no water in it, right? Just 2 marbles. Imagine that bucket is your pelvis. The marble will land at the floor of the pail. Now, in your pelvis, which is the pail, the floor is the pelvic floor. The marble will be on the floor. That's where the location of a normal ovary is in a normal circumstances. So your pelvis is like a bucket, like a pail, right? That's why cancer of the ovary is always very difficult to diagnose. Because a lot of times they grow and grow and grow with no symptom or very little symptoms, and only become symptomatic or the patient aware there's something wrong with me when the marble has left the bucket. The marble grow, and go to the brim of the bucket and say, hello, I'm here. right? When that happened, it's already stage 3. So 75% of ovarian cancer, as we speak, are still diagnosed in stage 3 and 4, which is sad. Late diagnosis. So it's a bane of this particular disease that we diagnose it late. And you know, when we deal with cancer, when you diagnose cancer late, the prognosis is rather poor, meaning the chance of cure, the chance that you're coming up from this disease is rather dismal, very poor, right? So therefore, we are encouraging people to be aware of their own risk profile. There are certain women who are more at risk to develop cancer of the ovaries. We call it risk profile. Next slide, please. Can we go quickly after the tumor? Well, I will explain to you about the risk profile in a short while. Okay, go back, depan. The first slide, lagi. Okay, this is an example of cancer of the ovary. You see how horrible it is? This is the uterus, this is cervix, this is one of the ovary that become very huge with a lot of nodules on it. Also, the other ovaries are similarly affected. This is typically cancer of the ovaries, which we have removed. Yeah, this is just an example. So ovarian cancer. Next slide, please. Same thing. When we do surgery for ovarian cancer, it's also a radical surgery. Not only we remove the uterus, the ovaries, and all the tumors in the ovary, we also need to remove the omentum, we call it. Omentum is a layer of fat in your tummy. There is a good spot to hide cancer cells, so they have to come off. We also have to sample some of the lymph nodes, and the appendix has to be removed. This is part and parcel of a complete surgery for ovarian cancer. Don't only remove the uterus with cancer, we remove that, we remove the omentum, some lymph nodes, and the appendix. If we not do any of this, we just remove this, that is not the complete treatment for cancer of the ovaries. I say this because often I get a query from the insurance company saying that, why you remove the appendix? Got nothing to do with cancer. Why you remove the appendix? If you open any gynae textbook, gynaecology textbook, that is the minimum treatment protocol for ovarian cancer. If I do not do this, I'm under treating my patient. All right. Next slide, please. Same, another example. Again, this is the uterus. Can you see that? Small ovary here. See how big this ovarian tumor is? Very solid. And the omentum as well, which is the fat in your tummy. So I'm just showing some example of ovarian cancer. Next slide, please. This is not too bad. Yeah, this is pretty clean compared to the other photos. Still a big tumor. Still a big tumor here, but very little ovary here. Again, the omentum, so it has been completely removed. Some example of specimen that I removed from some of my patients. Next slide. Again, some tumors can be not only watery, can be very solid tumor. Next slide. Okay, I wanted to tell you about the risk profile. Since it's difficult to diagnose, because 75% of the time they come up with stage 3 and 4. We need to know, we profile people who are more at risk. We need to know that. These are women who are at risk, who have obesity, has put PCOS. Both of the conditions may lead to what we call subfertility. Now, as I tell you now, subfertility can either be by choice also or inherent, meaning they try and nothing happened. By choice, maybe, well, they delay pregnancy because my career is important. I can understand all that. I'm not going to be judgmental, but you know that you are putting yourself at risk. Why is it that lack of children, lack of pregnancy is a risk? Very simple to understand. Your uterus, your ovaries, from the day you start having menses, will work every day and monthly produce an ovulation, monthly produce menses, right? But when you become pregnant, this function stops. Ovaries stop producing egg, correct? You stop having period. And if you after your delivery, you breastfeed your child, for example, your period will not come as well. So when this happens, your ovary, your uterus is taking a break, taking a holiday. Just like you and I, we all need a holiday, you know, we need a break. If you don't take a break, you break down, you know. You get stressed out, you develop high blood pressure, that kind of thing, you know. So ovaries and uterus need a holiday as well. So by being pregnant, sometimes you actually give yourself a break. So when the ovary and uterus work continuously non-stop, just like a car, you know, you drive your car every day non-stop, never send for servicing, never, you know, you only have one car, you drive every day, you break down. So when it breaks down, they become pathological as far as ovaries are concerned. So that's where you get it. Fertility treatment, why? Because we do know that stimulation of the ovaries, hyperstimulation, and the doctor will have to stimulate the ovaries to harvest eggs. But these are some of the risks that are involved with fertility treatment. We do know there's higher incidence of ovarian cancer in women who have gone through fertility treatment. So if this is your profile, then you must make sure that you regularly check your ovaries with your gynecologist. Now, if you have a strong family history of bowel, ovarian, and breast cancer, this is related to what we call the BRCA gene mutation. You heard about it, right? So you belong to that group. So these cancers are genetically linked. Breast, ovaries, and colon. If you have it in your family, you are a high-risk person. Never use an oral contraceptive pill is another indicator. If you're on the pill, again, you don't ovulate, you rest, your period become minimal, shorter. So regular usage for more than 3 years of birth control pill gives some degree of protection for ovarian cancer and ovarian cysts. All right. So if you have any of this risk profile, then you understand you are at a higher risk. So what do? Next slide, please. You must be aware of some of the early complaint that you already have the risk profile, and suddenly you'll be having all this epigastric discomfort, you know, just below your breast, your ribs. You feel, oh, it's painful, and people say that I have gastritis, and you take antacid, you take all kind of medication, no better. So if you have epigastric pain and you think you have gastritis, you take all the usual medication, you know better, then you better see a gynecologist, or even see a gastroenterologist for the first place, because a lot of these patients say, why should I see a gynecologist? I got this pain here. So go and see a gastroenterologist who will put a scope inside you anyway. They probably found a little bit of ulcer, give you medication, and still you're not better. And often some of these gastroenterologists will actually do a scan as well as part of their treatment plan for a patient with epigastric pain. And during the scan, they may discover an ovarian pathology. So often I get patient referred by my colleague from gastroenterology department who patient presented with epigastric pain, that kind of thing. Bloatedness, unexplained bloatedness, you know, whether you have had your meal or no, you just feel bloated. That's a bad sign. You must see a gynecologist because these are some early signs. So sometimes the gastroenterologist is the one who make a diagnosis of ovarian pathology and refer to us gynecologists to sort it out. All right, so that's a bit of ovarian cancer. And subsequently, next slide, please. Now, what is screening tool for ovarian cancer? Because it's so difficult to diagnose. These are some of the screening tools, not so reliable. What is reliable now, if you have a cancer marker, plus and the pelvic ultrasound together. Of course, I don't encourage this to be done on a routine basis, checking on your BRCA gene mutation status. You can go ahead and check. This day you can do that. You just say that, oh yeah, you have BRCA gene mutation. Yes, you're likely to develop cancer of the breast, colon, or ovaries. But I cannot tell you when that will happen. If you have a pair of breasts, you have a pair of ovaries, it will not tell you which breast will happen. It will not tell you which ovary and when. It will not tell you what types of cancer. It just tell you you're positive for gene mutation. So it's helpful in some way, but you're going to be quite depressed, I think. You know, you say, hey, I got this thing positive, you know, I'm going to get cancer, but I don't know when. But maybe by knowing a little bit of that, you become more aware about your symptoms. But of course, we don't want you to encourage you to become what we call hypochondriac. You know, every time silly complaint you have, I have ovarian cancer. It's not like that. So I'm worried that BRCA gene mutation done routinely may create that kind of environment. But what is more reliable, must be done together, yeah, not just by themselves. Tumor markers, as you know, the famous CA125, can be high even in many normal circumstances. Not the minute you have high CA125 doesn't mean you have cancer of the ovaries. On the day you have let's say you have a diarrhea, you eat the wrong food and you've been purging, you lose your CA125, it can go up. You have a bit of urine infection, you do your CA125, it can go up. All right. On the day of your menses, when you're menstruating, you do a cancer marker, it can go up. So it is not reliable. But if you do cancer marker, when you're pretty healthy and it goes up, you must combine that together with pelvic ultrasound. The marker alone will not tell you much. You need to do a pelvic ultrasound as well. So it has been shown in many advanced centers in the UK and America. If you combine doing regular tumor markers plus pelvic ultrasound, if you belong to the high-risk group, the chance of early diagnosis is possible. All right? So be clear with that. Do not just do tumor markers and be happy with it. Here you are, you have a risk profile. And I told you these are 2 things you do regularly, and if you discover, we act accordingly. That is to make sure that you are not going to be one of the 75% of patients with ovarian cancer who always come in late anyway. All right? Okay, next slide, please. The treatment for ovarian cancer is again surgery. It's a bit more aggressive. We call it chemo debulking. We call it radical surgery, sorry. We call it radical surgery. But sometimes when the tumor is so big, becomes stage 3 and 4, I tend not to do surgery right away, because it's going to be difficult for me to remove all the tumor in one go. It's difficult. So the newer method of treatment modality these days, if the patient comes in stage 3 and 4, is to shrink the tumor first with chemotherapy. We give 3 cycles of chemotherapy. This is what we call chemo debulking, meaning we give 3 cycles of chemotherapy first, shrink the tumor, make it less vascular, then we go and do an operation. Then we can do a good job to clean up all this tumor that I showed the photo just now. We remove all of that. All right? And then after you finish the surgery, 2 weeks later, resume 3 more courses of chemotherapy. Now, the level of chemotherapy, the type of chemotherapy is very dependent on the stage and on the type of cancer. So your doctor will discuss with you which is more appropriate based on your stage and the type of cancer that you are currently suffering from. All right? So these are some of the treatment protocols that we do for ovarian cancer. Next slide, please. Now we come into something very rare. You probably won't see it. These are cases that I see maybe 3 or 4 times a year, because I'm an oncologist. These cases, when they diagnose, they get referred to me. These are cancer of the vulva. Very rare, probably won't be one of your clients, because they're usually 70 to 80 to 90 years old. And that kind of 7, 8 decade of life is more common during this age group. So 60 and above. Now, a lot of women say, I'm already 60 years old, I shouldn't see a gynecologist. What is the guy going to do with me? I got no more period, I'm not going to have babies, But there are other conditions that can arise in the skin of the vulva. The vulva is the entry of the vagina, the 2 lips. Yeah. So cancer can arise from there. And just like cancer of the uterus, these women sometimes come in early, unless they live by themselves. Most of the sad cases I've seen are women who are abandoned in the old folks' home sometimes, no relatives around. They are very much on their own. They have no idea what's going on. They say, I'm having this lump, it's bleeding all the time. I thought it's an ulcer, I've been bitten by a rat, whatever, that kind of story sometimes we hear. But if they live with someone, they probably complain that, hey, I have this lump, it's bleeding, so let's see a gynecologist. So it's quite easy to diagnose because it's so visible, it's staring at you. You immediately ask the patient to undress, you can see there's a very fleshy, usually very vascular, very easily bleed kind of lump coming from the skin of the vulva. And we normally confirm by taking a biopsy. Treatment's quite, yeah, once confirmed, I'll show you some photos. Slide, please. The mainstay of treatment is surgery. And in the old days, when I started in this field in way back in 1982, the surgery is so massive. A lot of these women have tons of complications. They are very old, their skin is not very healthy. We do a big cut and sometimes we can't close back the skin and we left the lesion to heal by itself. It takes months, and some of these patients do not succumb to the disease, but succumb to the surgery. But as I say, medicine is always in the forefront of technology. We try to improve ourselves. We study the disease again. Say, isn't there a better way of doing this so our patient won't suffer so much? Yes, there is. We call it a new method called triple incisions. Triple incision, where the tumor is removed by 3 small, separately located incisions on the skin, and that is the mainstay of treatment now. And I do about 3 or 4 a year because there are not that many cases anyway. And they have excellent results. Most of the women will be okay. There's one cancer that they normally survive and thrive because they come in early. And the surgery now has been modified to cater for the cancer in a more consistent way so that the patient can recover faster. Again, I say the mainstay, the crux of our duty here is to ensure the patient remain well and can return to being productive as a housewife, as a grandmother, whatever, and able to function as normal as possible. So triple incision is a new modality treatment as opposed to what we call butterfly incision, like really a big butterfly cut away in your vagina. Next slide, please. Some example of cancer of the vulva. See, this is the 2 thigh. This is obviously a neglected case where the cancer started. This is the vulva, started from the vulva, spreading up to the anus. Nothing much we can do. This particular instant, we give a bit of radiation to shrink it. So when we can't do surgery because it's very advanced, we try to irradiate it. It does work as well because they do respond to radiotherapy, but the radiation can also cause a lot of problem to the normal surrounding skin. But we can't operate in cases like this. It's so advanced already, right? So we don't want it to come to that stage. You should come see a doctor when there was just a little lump there bleeding. So yes, you still need to see your gynecologist even though you're 60, 70 or 80 years old. He will not do a pap smear because your risk for cancer of the cervix is so remote. Doing a pap smear on you is quite ridiculous. But a vaginal inspection, looking and examining is important. Next slide, please. Now, again, I don't have a photo for this. This is very rare. This is just to complete the series of cancer that I need to talk about. Cancer of the vagina. You see, just now you say cancer of the vulva. What is cancer of the vagina? Okay, vulva is the lips. And you see the lips in your vulva, that's the vulva, left and right. If you go to the tunnel, that's the vagina. The vagina is the tunnel. All right, it's about 5 or 6 inches long. You can get cancer there as well. But often, cancer of the vagina do not arise from there. It comes from somewhere else. It usually comes from the cervical cancer. It can even come from cancer of the uterus. Now, last week I had a case, it came from her ovaries, cancer of the ovaries, a recurrent. So, cancer of the vagina usually may not arise from there, but actually the origin is somewhere else that migrated there. So, if the woman still have her uterus inside her, and she has cancer of the vagina, we have to examine the uterus carefully, because sometimes there's cancer in the ovaries or in the uterus as well. We have had cases as well where women have hysterectomy done already for fibroid, for whatever, but came with cancer of the vagina. This probably because sometimes they already had a pre-existing precancerous lesion of the cervix when the surgeon removed the uterus, but there was no follow-up. It may appear as cancer of the vagina. So I just want to mention it in passing because it's very rare, but it does happen once in a while. Even though I say once in a while, I had one case just last week but it came from somewhere else. Okay. All right. Next slide, please. Okay, just to complete the treatment protocol. I mean, nowadays patients are very up to date. You know, they go and consult Dr. Google. You know, they say, "Isn't there any other way how to treat my cancer? You're talking about surgery all the time, radiotherapy, chemotherapy. Isn't there any other thing?" Yeah, of course, there are many other things on the horizon. Other thing in the horizon: immunotherapy, targeted therapy, and also new modality of chemotherapy. I've been told I've got a few more minutes left, so I'm going to just mention that in passing. Next slide, please. I have mentioned this already. Can we go to the other section, the elimination one? I want to spend a bit more time about cancer of the cervix. This is how we do Da Vinci. Yeah, this is me looking at the console, doing surgery remotely, and we're doing this regularly now in Gleneagle. Just a method of doing surgery, the keyhole robotic surgery. I'm going to spend a bit more time. I told you just now while Serena is getting the slide ready. Now, cancer of the cervix is one preventable cancer. 70% of the time is caused by a virus called HPV. And there are many types. The commonest one that causes cancer of the cervix is type 16, 18, 45, 51, 52, and 58. We think we can eradicate this cancer. Why? Because it's caused 70% and caused by the virus. We have vaccines. We have vaccine now. Government give it free to schoolgirls, right? But if you pass that, you're not schoolgirl anymore, you have to buy yourself. So vaccinations. That's the mainstay of this is called what we call primary prevention. The next level of next slide, please, is doing a pap smear. So a lot of women think that this will be my last slide, yeah, because the way to prevent cancer of the cervix is two-pronged. One is primary prevention, vaccination by the vaccine against the virus. Second prong is regular pap smear. Now, if you're a patient, if you're a lady that will do both of this, your chance of getting cancer of the cervix is almost zero. Why? Because if ever you're going to get cancer of the cervix, it comes in a very, very early stage, we call it CIN or pre-cancer, where we can detect by a pap smear. You do not have to lose your uterus. You just lose a little bit of your cervix by us doing a procedure called colposcopy. So I can assure you, if you've been vaccinated, you have your regular pap smear, if ever something is wrong with you, it can be detected early. You're not going to get cancer of the cervix. By doing these two methods, two-pronged, we are pretty confident we can eliminate cancer of the cervix. Now, there's a challenge for all of us doctors, especially doctors in my fraternity, to encourage people to do all this. It's difficult. But if you have the capacity, if you have the resources to do all this, do not deny yourself. And being a part of a health provider kind of group, because you see people, you see clients, you know, do impress on them that this is one cancer we doctors and ourselves like to prevent and eradicate. All right. Thank you very much. I think, and
Thank you.
If you want to ask me any question, if I can answer them, I will try my best to do so. Thank you.
Yes, thank you, Doctor. Thank you for your very thorough explanation of the different types of cancers and how it will diagnosis and also some of the treatment. Okay, it's really valuable information for everyone, you know, regardless whether you're a woman or a man. Okay, we have questions in our registration form. So our guests, our participants in our talk are mostly the general public who have been with us for the past 2 years. So if you have any questions that you'd like to ask Datuk, please feel free to put into the chat box and then he will answer later. So the first question we have for Datuk, okay, in our registration form is, what are the symptoms and preventions before HPV vaccine? What is the accurate brand? Gardasil 6 or 9?
Well, there are only two types of HPV vaccines. Yeah, one produced by GSK, it's called Savarix. One by MSD called Gardasil. I think Savarix is not readily available now because, as far as I know, it is being utilized by the Ministry of Health mainly to be given to schoolgirls free. So for the lay public, Gardasil is the one that we have, and it has been upgraded to Gardasil 9, and all the older Gardasil is out of in production already. So it's if you want to be vaccinated, there's only one available now, Gardasil 9. So there's not much choice there, but they do work pretty well. So I highly recommend you go for it. But if you have daughters in school, by the time they're 13, don't deny them, because as parents, you'll be asked for your permission to have your daughter vaccinated in school. Let them have those vaccines.
Right. Okay. So regard to the first question, what are the symptoms of prevention before HPV vaccine? I think that was related to a cervical cancer, right? Cancer at the cervix.
Yeah. Well, the symptoms, as I mentioned just now earlier in my lecture, intermenstrual bleeding, when you stop having your period, it comes back. The other one is, of course, bleeding during or after intercourse. Yeah. These are some of the symptoms that we are saying is important for you to pay attention to, and do not prevent yourself from seeing a doctor. Now, the vaccine came to Malaysia in 2007. It's been around since the year 2000. All right. So we feel that this cancer is doable. We can actually manage it and prevent it. Of course, before the vaccine comes, this is what we are asking to do, pap smear. But now if we do both vaccination and pap smear, the chances of getting cancer is very low. So that's what my recommendation, and I think that's recommendation worldwide as well. And WHO is talking about elimination of cancer now.
So, Datuk, I have one question for you regarding on the HPV vaccination. Previously, we have speaker that shared that maybe HPV vaccination should be introduced to boys as well. What is your thoughts for that?
Well, that's true. I mean, I have a son. When he turned 14, because they were in private school, they have no access to the free vaccine by the government. So for my son, I give it to him. Because in certain countries, they give for both boys and girls, because boys are the one who pass it to the girls, and girl who pass it to the next boy, for example, right? We cannot stop human from having sex. Whatever you say, you can be an ostrich and bury your head in the sand, but you cannot run away from the fact that children, young people have sex all the time, and we can't control it sometimes. So therefore, we need to do that. So if you can afford it, yes, give it to your boys. And certain countries like Australia, UK, they give to the boys.
Yeah. So young boys, I mean, they don't get the free vaccination from the government, not like the girls. Yeah. So the boys would have to, the parents would have to pay for it. Yes. Right. The next question that we have a participant that say that she is in a BC stage 2, 2016 under tamoxifen medication. Since I took the tamoxifen, I haven't had my period. But after 2.5 years, suddenly period came. My specialist doctor referred me to gynecology. From the test results, I was diagnosed with HSIL. Then I underwent hysteroscopy, coloscopy, and cone biopsy on August 2020. I'm still up on follow check-up. Recently, I have found that I have a cyst in my ovary. The latest result from my pap smear still have LSIL. The doctor suggested that I remove my ovaries. I'm scheduled to do a colposcopy and a biopsy in 2 months. Do I have to remove my ovaries? Is there no other way? I'm very worried.
Well, it's always difficult to give a management plan for someone like that on this platform. But what is been offered to you is not for it is obviously going in the right directions. If you have breast cancer, you'll be given tamoxifen. Now, tamoxifen may stimulate the lining in the uterus, and we do know that breast cancer can spread to the uterus as well, and the ovaries. So when you have breast cancer, if you have lesion in the uterus, you have lesion in the cervix, you have lesion in the ovaries, I think it is in your interest. I think you're the chaps looking after you is doing the right thing for you. And I think you should, do that, because the risk is too high for you.
Agree that it's not easy, right? As you mentioned, to do planning. So make an appointment, okay, if you need a second opinion. The next question we have from the registration form is, 2 years ago, I was diagnosed with adult granulosa 1C1. I had hysterectomy and chemo. Now I am okay. What is the survival rate for this type of cancer?
Okay, granulosa tumor is from the ovaries, not from the uterus. But if obviously you had a total hysterectomy done and there was a tumor in the ovaries, and they diagnosed it as a granulosa cell tumor. I'm not very sure whether you're given chemotherapy because it all depends on the stage of your tumor. Now, if you have a stage 1, meaning the tumor is only confined to that ovary, hasn't spread to the lymph nodes, the liquid around in your tummy is negative for cancer cell, you're stage 1, essentially a very early tumor. So chance of survival is almost 95%, 5-year survival rate. Now, talking about survival rate, they are not just numbers that you need to follow strictly. These are just guides. Yeah. When you have cancer of the gynecological cancer, our follow-up protocol is 5 years. Most gynecological cancer, if they don't come back or recur after 5 years, unlikely for them to come back and bother you. It's not breast cancer. Breast cancer can come back anytime. So there's a follow-up protocol, very strict. The protocol usually involves for ovarian cancer involving a regular blood test, cancer marker, maybe 1 in 6 months, an annual MRI. If the MRI shows something unusual, we even recommend PET scan. So this is a follow-up protocol. So to answer you simply like that, it's going to be difficult because I think you have to understand what is the stage of your tumor first, and we need to correlate that with your chance survival rate according to the 5-year prognosis. Yeah, maybe you can sit down with your gynecologist and discuss that thoroughly, because I think it's an important question to answer, and I do not want to give a wrong answer here because I do not know your stage.
Thank you, Datuk. Now we have questions in the chat box. What are the symptoms for ovarian cancer?
I think we went there in one of the slides.
Yep.
The symptom I told you, bloatedness, epigastric pain that's not getting any better after all the investigation and treatment, essentially bloatedness in the early stage, right? By the late stage, you can feel your tummy has grown bigger, like a little balloon, because the cancer produces a lot of liquid. We call it ascites. We had an abdominal distension. Yeah, that is already probably stage 3.
In your photos, have shown that the ovarian cancers are really huge, so much bigger than the uterus and the cervix. Next question we have is, how regular should one do PEP test? I think PEP test, polypep smear, PAP, after total hysterectomy. Patient is 71-year-old, must she still do PEP smear?
Okay, if she's 70 years old, you said it's now 70 plus, right? Now, if
21.
Yeah, if the hysterectomy was done for something benign, meaning non-cancerous, right? Maybe it was done for fibroid or cyst, benign, they're non-cancerous. She doesn't need to do a pap smear anymore, but she should go and check the skin of her private part and again. Pap smear can be omitted. But if the hysterectomy was done for cancer or pre-cancer, she should continue with what we call a vault smear, which is also a pap smear, but there's no more cervix, so the vagina end up a little vault. We call it, you take a smear from the vault of the vagina, if the hysterectomy was done for cancerous lesion. All right.
Okay, so that answers the question. Next question you have, Datuk, is that a friend has spot bleeding, seeing doctor for endometriosis. What is your advice?
Can you repeat? The patient has stopped having menses?
No, a friend has spot bleeding, and right now she is seeing doctor for endometriosis. What is your advice?
The endometriosis is obviously giving her the spotting, right? So endometriosis can be treated usually in 2 ways or in combinations. First of all, it has to be confirmed first. It has to be, the doctor had to confirm that really dealing with endometriosis here, based on history taking, by asking certain questions about her menstrual pattern, by doing an ultrasound. Then the endometriotic cyst can be visible. If it is not so visible, but the suspicion is very high, the doctor will put a camera in, we call laparoscopy, to see the structure in the pelvis, the uterus and the ovary, whether they have early endometriosis. So once confirmed, if the endometriosis in a very early stage 1, we also grade endometriosis into level, right? If it's very early, when there's no lesion, just black spots or endometriosis in the pelvis, medication is sufficient. And this medication usually will stop your period for at least 9 months. But if the endometriosis has caused enlargement of your ovaries or uterus, obviously surgery needs to be done first to remove all this pathology, followed by medication. So step by step, yeah?
So there's a lot of steps related to that. So best is actually to plan your scheduled treatment more with your doctor. Next, sorry, doctor, isn't it easy? Isn't easy to get BRCA done together with the body health screening? This on the gene.
No, it's
gene
not,
test.
not difficult. It's available, in the lab. You can come and we can do it for you. That's not a problem. Yeah.
Okay, so yes, it's easy, can be easily done. Next question we have, okay, doctor, how frequent for a woman to do pap smear after menopause?
Okay. Yeah, that they remain the same as I told you just now. Pap smear should be done basically the best is actually once a year. But I know it's difficult. Women tend to forget. But if she is a non-smoker, her pap smear all in the past has been normal. She's non-smoker. She can even delay it by once in 2 years. In certain countries now, I'll give you an example in Australia now. They've done this very successfully, knowing very well that cancer of the cervix is closely linked to HPV, and knowing very well that many women find it difficult to come up for an annual or once in 2 years pap smear. They do the HPV genotyping. They go and check whether you have HPV or not. If I do the HPV testing today and you're negative, you have no worries. You can repeat the test after 5 years. So instead of coming every year, every 2 years to do this test, they do the test on a higher plane, higher scale now. They don't do pap smear anymore. They do what we call HPV genotyping, whether you have HPV or not. If you have no HPV, your risk is very small. So I think that's another way of looking at it. We can do the same here. I think the group, the Rose Foundation in MU, Ismlaya, is trying to launch something similar the way the Australians are doing it. They call the COMPASS study, where they have shown that cost of care, to the women and to the hospital is much lesser when compared to do an annual smear, but by doing a 5-yearly HPV genotyping.
I have heard of that. That I think it's like a brush that is can insert it, and there's also actually I think home availability that you can do it on your own or at the clinic.
That's right. Yes.
Okay. So we have about 3 more questions. Next question. I had my uterus removed 5 years ago. I still have my ovary. What test should I do when I do health screening to avoid cancer?
Well, if you are still, you won't know when you reach menopause because you have no more uterus, right? So you have starving period, but you still have your ovaries there. So if you're still not 50 years old, you may not reach menopause yet. But if you are 50 and above, you can know whether you're menopause or not by doing a blood test to check on your hormones, right? But in your case, if both ovaries are still there and you're not 50 years old, the ovaries are still functioning. So an annual pelvic scan is sufficient. If the doctor sees some lesion in the ovaries, perhaps he can offer you a CA125 as well. So scan and blood test is sufficient if you still have your ovaries and you haven't reached menopause by doing a blood test. Yeah. If you reach menopause, the chance of you getting ovarian cyst is very small because the ovaries already shrunk anyway, right? Yeah.
So the blood test you're referring is for the cancer tumor marker?
That's right. My apologies. CA125. That's right.
CA125. Okay. Next question we have. What are the reasons for having burning sensation? Prior to that, there was opaque discharge, but now no more. Doctor, are you able to answer this?
I presume you're talking about burning sensation, your private part, right? Obviously. So, burning sensation is usually can be related to either skin dryness or infections, right? So you probably want to have, let's say, a swab test done in your vaginal canal, see if there's any bacteria there. And also take a urine sample and culture it for 48 hours, see whether you have any bacteria growing in your urine. So the burning sensation is usually typically due to infection in nature, both either in the vaginal canal or in the bladder. Both need to be checked by doing a culture studies.
Because I think when women they have UTI, they also have that burning sensation. So it could be an infection.
Could be that,
okay.
Yeah.
Second last question that we have, is pap smear needed for non-sexually active women?
Okay, this has to be answered very clearly so that people understand. Pap smears are done on women who are sexually active currently or in the past. All right. So you may not be sexually active now, but you were sexually active before. So you need a pap smear. If you are a real virgin, meaning you never had intercourse in your life, ever, you do not need a pap smear. The minute you resume intercourse, whether you're married or otherwise, this is a real life, real world situation. Yeah, people have intercourse out of the marriage. So it doesn't matter. We're not judgmental here. Look after yourself, do a pap smear. So the answer to that question now is, if you have been sexually active in the past, but you're not active now, do a pap smear. But if you've never been sexually active, ever, you don't need a pap smear.
It's clear, Datuk. Last question that we have from the chat box is, what are the chances that BC patients, so I think that's breast cancer patients, will lead to gynecology cancer at later stage?
Yeah, a very good question, because I think your breast surgeon who treated you for breast cancer will always tell you, especially on tamoxifen, like our lady, the previous questions, should have a pelvic scan done regularly, at least once 6 months. I do have combined follow-up with my breast cancer surgeon, where the patients on chemotherapy, tamoxifen, they send to us for a ultrasound of the pelvis to check on the lining of the uterine lining, and also for her ovaries. It's a good practice to do that, because breast cancer very fond to go to those two organs in the ovaries and pelvis. Yeah, I think it's very relevant.
So have a pelvic scan every 6 months. That's the advice.
Yeah, I think that's very.
Okay, so that's the end of the question that we have for Datuk today. Thank you so much. It's really appreciated with all the information and the answer that you have for our guest today. Okay, I myself gained so much. I'm sure everyone attended today has also gained a lot. So if you would like to make an appointment to see Datuk, okay, Datuk Abdul Aziz, all right, please have put in front of me his contact. He's in Gleneagles, okay, level 5, 5th floor, and then the phone number for you to make an appointment. Okay, when you make an appointment with Datuk, then you'll be able to speak more and also ask him more questions, okay, for his consultation. All right. Yeah, I found this in the in Google, so I'm sure you can search it easily, or you can call Gleneagles main number to make an appointment. So our feedback form, please give us your feedback on what do you think of Datuk's sharing today. I think Datuk's sharing is very impressive, and it has been very thorough. Okay, so it has really given us as a woman on what are the possible cancer there are, what are the diagnoses, what are the symptoms, and also the treatment. Okay, I heard your feedback about robotic treatment, okay, on the insurance company. I will definitely pass a message, okay, to the insurer. Thank you, Datuk. Okay, so Gleneagles, thank you so much, Gleneagles Hospital Kuala Lumpur, specifically to the marketing team, Sarina, for being with us in the past 2 years. Follow their social media in their Facebook, in the Instagram, and so LinkedIn, because they post regular information about health, okay, on their websites. All right, so do that. So the Pioneers Financial Services part Prudential. So Prudential, great news that we are covering COVID-19 and all future pandemic since the beginning of this year. This means that if you are a Prudential client and you need to be hospitalized to our panel hospital due to COVID or future pandemic, Prudential will be issue a seamless claim experience, cashless facility to all our panel hospitals. All right. If you need to find out more, please approach any of us or myself, to get more info. So our next health talk is going to be on the 22nd of May. That will be after Raya, which is the first week of May, and also after the Vesak holiday on the second week of May. So there's a lot of celebration and public holiday ongoing. I think with the borders open probably, and also Raya, because I think this year, after 2 years, is our first time, all our Malaysian friends, especially our Muslim friends who are celebrating Ramadan and also New Year, Raya with their friends, and family as a group. So our next talk is going to be 22nd of May. Okay, it's always a Sunday at 3 o'clock. All right, usually our talk run for about 1 hour to 1.5 hours. Okay, the topic will be, how should I respond to emergency situations? Okay, I think it's a very important topic, because sometimes we forgot what should we do. Okay, so we'll give you more information, but please register first. This is our QR code. If you're unable to access your QR code, our team will send you an email or a WhatsApp message later with the link. Okay. So this is me. All right, this is my digital name card. Scan in to get in touch with me, if WhatsApp or email, okay, or get into my social media with LinkedIn, Instagram, and also Facebook. All right, so that we can keep in touch. Okay, and this is the group that I'm working together with. It's called the Pioneers, our co-hosts that work together to make sure that the team our guests are getting all the information that we need for our virtual talk. Thank you so much for your support and keeping us going for the past 2 years. All right, so we're expanding. If you yourself or know anyone who would like to join a team of financial planning, let us know. Okay, reach out to us to find out more about building this career, which is a pandemic and recession proof. All right, we're also in YouTube channel. So for those who have late or probably missed out or left early, okay, do not be worried because every talk that we have, okay, has been uploaded to YouTube. So scan to go to our YouTube channel, subscribe so that you get notified each time we upload a new video. All right, so this is the last slide for today, our feedback form and our next Health Talk registration form. Thank you so much once again, especially to Datuk for being with us today. Sarina, our fantastic guest, has been coming in with many interesting questions, okay, who are constantly wanting to learn more. Okay, thank you so much for your support. Wishing everybody a fantastic rest of Ramadan month. Selamat Hari Raya in advance, because I will see you after the first week of Raya celebration. Take good care and stay safe. Okay, bye everyone. Thank you. Thank you, Datuk.
Thank you, Amy.
Thank you, Sarina. Thank you. Thanks, everyone.